Okay, so when we were last talking, we were talking about these pediatric injury patterns. We listed off some of the things that you might expect to see in an adult in, say, a car collision. And I don't think we'd really gotten to pediatric. I don't think we'd gotten very far into that before the fire alarm went off. So when we're talking pediatric, well, first of all, do you remember what we talked about for adults? We talked about things like steering wheel, potentially if they were the driver, seatbelt, bruises, leg fractures like hitting the dashboard, right? Obviously whiplash, like maybe head injuries. For kids, for pediatric patients, you're still going to see the same kind of head and neck injuries, especially if they're unrestrained. I mean, even more so, kids can, if they don't have a seatbelt on, they can really get lifted up out of their seat and move around violently in the car. Even if they are restrained, you may see some of that stuff like the whiplash, but you also are going to expect to see abdominal injuries and lower spinal injuries. So y'all know that kids are supposed to be in car seats, right, up to like age 8. That's because the way that the seatbelt rides, like it's supposed to go across your pelvis. And so if you have an injury or if you have a collision, it'll hit on the bones and, it'll hurt, but it's not going to press in anywhere that it shouldn't. For kids, most of the time, if they're not wearing or they don't have a booster seat or a car seat or something, their bodies are just shaped differently, and so it's going to be hitting right across the abdomen and like pressing in real hard on all those soft organs. So if you've got a kid who is wearing a seatbelt and they're at all small, or if they're under age 8, or if they weren't in a booster seat, just be aware that there's probably going to be abdominal injuries, lower spinal injuries, because the seatbelt just doesn't fit them well. You may also see injuries like around the head and neck kind of area. Again, those seatbelts usually don't fit them properly, so they may be riding up too high, and you'll see abrasions or lacerations potentially on the side of the neck, along with the regular seatbelt injuries and things like that. If it's a patient who, say, was like riding a bike or walking or something that was outside of a vehicle, obviously you're going to see head injuries. Again, anything that throws that patient some distance is probably going to cause some sort of head, neck, spine injury. Be aware that you may also see abdominal injuries and also lower extremity injuries. So thinking about if a kid's walking along and a car hits them, where's that, like the nose or the tip of the car probably going to end up hitting, like the bumper? Yeah, somewhere on the legs. So usually like upper leg, more likely than not. For adults, it might be more on the lower side of the leg. I mean, it depends on the car, obviously. If you've got like a jacked up truck, it's going to hit them differently versus like somebody driving a Fiat. So it's going to depend on the car, but in general, you can predict the kind of range of injuries that you might see on a pediatric patient, as well as an adult patient, but they'll be a little bit different. Okay, so this is something that we don't do in Texas. Y'all have used the KED, right? We did the KED because we did that thing in the cars and pulled, yeah. This is something you can't do in Texas, but in other states it is allowed, so we just kind of show what it is. You can immobilize a child using a KED, just like you might use a long backboard. It's got those strips, the boning type strips, whatever they're made out of, that form its like rigid structure that can kind of wrap around. And so you can see that it fits around the kid pretty well, up at the head and then around the torso. It's just, why would this maybe be a bad idea? Why do you think Texas might have made it illegal? Okay. Well, remember, it is going up behind the back, but yeah, I guess there's not really as much like right here maybe. What else? These things are really, really strong and sturdy, right? And it's easy to pull them nice and tight, and they've got great straps. But if you've got a kid whose chest is already fragile and who maybe is like struggling to breathe or other things, do you think this is going to make their breathing any easier? Okay. There have been issues of children actually getting partially asphyxiated because of these, because they're just strapped in so darn tight. That's why they're not allowed in Texas. That's the same reason why, like for psychotic patients, they used to put a backboard underneath them and a backboard on top of them and like strap around the whole thing just to protect them and like make sure they couldn't reach anywhere because they were really strapped in. They don't do that anymore either. Same thing. That kind of tight wrapping where there's something really hard on top of the body can cause it to become really, really hard to breathe. So remember, it's not just like a regular backboard because it's got the sides, those rigid sides that if you're wrapping them over, all of a sudden it's like an iron, it's not iron, but it's like a stiff band completely encircling their abdomen or their chest, and that's what makes it so dangerous. Okay, so we've talked a little bit about burns as far as adults go. Burns are pretty common for pediatric patients. Y'all should remember in your, I think it's the soft tissue trauma chapter, but it talks about burns. It talks about the rule of nines. Y'all remember that? Remember going over it? Just be aware, go back to that in your book and look at it, because the nines, and the rule is a little bit different for pediatric patients. Remember, heads being larger overall, the heads take up more percentage of the body surface area, so some is taken away from, I think the legs is slightly less, so the head can be slightly more. But just check that in your book, because they offer a couple different, like for babies versus young kids versus slightly older kids. If you have a pediatric patient with burns, obviously you want to take them to somewhere that can deal with burns as well as just pediatric trauma. So it's another level up in terms of the kind of care that they need. Just otherwise, you treat them pretty much the same as you would for any adult patient who has burns. You want to go ahead and cover the burns with a sterile dressing, not something that'll stick to their skin. Keep the airway open, suction. Remember, with burns, especially any kind of burns around the face and neck, you're concerned about airway closing because of all that swelling. To transport them immediately. And the reason why we say to immobilize them is really just so that, because the burns are so painful, immobilizing them allows you to kind of keep their whole body from moving any more than is necessary. It's part of the protocols that we use. So if you're doing trauma assessment on a pediatric patient, same thing as you would do for an adult. It's got to be rapid. So trauma meaning you're trying to find out anything that's wrong with your patient. You have to do it quickly so you can find whatever there is as quickly as possible to treat it. You want to look for any life-threatening conditions. Again, same as an adult. And again, same thing, head to toe. We did talk about how for medical assessment you try to start at the feet first. Y'all remember that from Thursday? You try to start with the maybe less threatening parts of the body first for a medical assessment. For a trauma assessment, this is when the kid's been, in some sort of trauma, car accident, burn, whatever. You want to go ahead and just do the quickest, most efficient assessment you can. Taking your time and being gentle with the child. You want to be gentle, but taking your time and you're kind of catering to their feelings is not going to be as good for them as just properly assessing them right away so that you can treat them better. Okay, so this is what's in your book, talking about the burns. They show what it is for a child and then for an infant. Let's see, what are the differences? So, actually, I think there may be even another one in your book. But you can see how the legs are 18 apiece in adults, and then in kids and babies are 7 apiece, meaning 7 front and 7 back. And then for an adult, the head overall was 9%, and for children and infants, they say that it's 18%. So be aware of these differences because they make a difference in terms of if you have to calculate burn percentage. And for the test, there's a chance, I don't remember too well, but you may have a question like this. It's real subjective. Not everybody gets the same questions, but there may be something where you have to calculate burn percentage or calculate burn percentage and tell us whether or not that's a minor versus a critical type burn. So you're going to have to know this stuff. Child abuse and neglect is something that you may come across as an EMT. So this is an example of what a child abuse injury might be. This is burns to the feet. Something that is, I guess, semi-common but burning is a pretty, I guess, effective way for child abusers to somehow punish the child that they think is doing something wrong. That's usually what it ends up being. It's like, you got into mom's makeup, you're going to pay for it. That's the kind of rationale they use. You'll see, they call it gloving, people putting their child's hands in a pot of boiling water, or the feet in a pot of boiling water, or the buttocks, because those are areas that they can, I guess, fairly easily access to do that kind of trauma to. So this is an example of the burns that you might see. If you see this kind of thing, this is not typical child trauma that they would just casually come across. They didn't randomly walk on a hot griddle by themselves. Somebody did this to them. Be aware that if you are dealing with a patient that shows some of these signs, they may be signs of abuse, whether physical or sexual. So be aware that any one of these is not absolutely a sign of their parent or their guardian did something to them. You kind of have to take the situation as a whole, look at all the injuries, not just the current ones, but any kind of residual ones that you can see. So bruises not just fresh ones, but maybe like patterns of bruises where you've got some that are in various stages of healing, meaning that the kid has probably been bruised repeatedly for a longer period of time. If you see any of these marks on areas of the body that don't easily happen, so it's more of a sign that it's abuse versus just somehow something else going wrong. For example, a kid might reasonably like burn a couple of their fingers by touching something hot. That's reasonable. The kid's not randomly probably going to sit down on a stove. Burn marks on the bottom, that's a little bit unusual. Bruises all along the shin, that's fairly normal, okay? Kids run into something, that may just be something that happens. Don't automatically assume that that's a sign of abuse, just because there's a lot of bruising on the lower legs. However, if there's a lot of bruising on like the inner thighs, or like the sides right here, places that don't normally get hit just casually in terms of like how kids act, those are good signs that somebody is doing something to the child and trying to cover it up. They usually tend to abuse on parts of the body that aren't as obvious. And so if you see those marks on areas of the body that don't seem normal, that's also a good sign. So, sorry?
Can you call child agents? I forgot the name.
Yes. Actually, it's your requirement to call and report possible child abuse if you suspect it. It won't come back. I think there's probably a slide on this, but it won't come back on you as somehow a mark against you if you call and it ends up not being the case. But you're actually required. It's one of those, you don't have to report everything that you see as an EMT. It's not your job to report certain stuff, but any sort of homicide or death, abuse situation, like a dog that bites or something like that, animal related, those are all things you do have to report. Because there's agencies to try to deal with those types of problems. So anyways, some of the things that you might see just in general. Slap marks, obviously if your kid's got like a adult size handprint on their face, that's not just a normal injury. Bruises, abrasions, lacerations, incisions, like I said, those are things that a kid might naturally have from bumping into something or running through, a thorn bush or whatever. Kids do things that they hurt themselves. You have to look at the pattern of all of these injuries. Broken bones, for sure. Head injuries, abdominal injuries, bite marks are kind of a real good sign. True, it could just be the kid's kid brother, and they're maybe having a fight. Again, it's not an automatic sign that abuse is happening, but it's one of those things that if you see it, if it's a large mouth bite mark on a child, that is not normal. None of these things are normal. They should at least be investigated. You should look at them and try to assess overall. Burn marks, like we already talked about. Along with the actual injuries that may or may not exist on the child, there's certain things you can kind of see in your environment that might lead you to think that the adult is abusing the child. One of those things is actually what might be considered inappropriate or over concern for the child. It's totally normal for a mom to be upset that her kid is hurting, crying, screaming, whatever. It's not so normal for the kid to try, or for the mom to try to rush in and comfort the child and tell the EMT, no, we're okay, you don't need to be here, you go away. Or you just kind of have to use your gut in terms of, are they acting like how a normal mother would act, or are they acting like somebody who has something to hide? That's what we're talking about, this inappropriate concern. If they seem to have trouble controlling their anger towards you, towards the child, towards other people around them, if they seem like they're lashing out really inappropriately just while you're around, that's a sign that maybe they're not controlling their anger at other times either. Again, these are all just possible indicators. This is not like a hard and fast rule by any means. If the adult seems to be in a deep depression, if it seems like there's a lot of alcohol or drug use, if the adult seems to have suicidal thoughts, these are all potential indicators that the adult is an abuser. I don't think we have a slide on it, but you also want to look at the environment that the kid's in. If it looks like an environment where they're well taken care of versus an environment that's full of neglect, where possibly it's very dirty, or they seem to be not having the ability for proper hygiene in terms of cleanliness, in terms of, stuff around. Those are just possible signs that maybe something in this environment isn't good for the kid. A parent who is, flying off the handle at you and living in squalor, and then their kid has some suspicious injuries, that'd be something that you might want to talk to your supervisor and say, hey, based on what I saw today, this is what I think might be going on in this family. Again, that's your job. You take care of the patient first. You provide whatever appropriate care you need to transport them, preserve any evidence that you may find on the patient. It's not your job to be some sort of investigator and discover things in the house, but on the patient themselves, any sort of evidence, bloody clothing or something like that. Go ahead and preserve that and bring that along with. So yeah, you gather information from the adults, trying not to offer judgment because that's not going to help this go smoothly. If you fly off at the handle and get upset at a parent that you believe to be abusing their child, it's not going to improve the situation any, and then you're probably going to get in trouble as well. Try to talk to the child separately. Like I said, that inappropriate level of concern from the parent, try to find an excuse to kind of get the child by themselves so you can ask those questions without the mother or the father or whoever butting in and kind of trying to answer for them or masking whatever the real answers might be. If you see that the child seems really afraid of their parent for some reason or is constantly looking to their parent for like saying the right thing, try to go ahead and get the kid away from the parent. It may not even be abuse. It may just be some other secret they're trying to hide, but you do want to get good answers. And so if getting the child and the parent separated is the best way to get good answers, try to find an appropriate way to do that. And if you do suspect something based on what you have seen and observed within the family, the house, and obviously the child's injuries, you have to report it, report what you saw, just your conclusion or rather your suspicion of what may have happened to the medical staff. They'll take it from there. It's no longer your job. And like I said, you're not going to get in trouble for reporting your suspicions if they end up not being true. It's your duty to report it. Remember that we don't want to say that this mother definitively abused her child. We use terms like suspected and possible because we don't actually know for sure. So you suspect that this mother has abused their child. You don't say straight up, this mother is abusive. Because, again, that's not your call. You're not the investigators. You're not the one that can tell that. You're just telling your suspicions to the correct people who can investigate that or find out the truth. Okay. We're going to talk, it's not super long, a few things about infants and children with special challenges, meaning like pre-existing conditions that may slightly change the way you interact with them. Okay, so respiratory issues in general are one of the most common challenges that you may already have a patient facing. Remember we talked about premature infants with the surfactant in their lungs, how their lungs don't always work as well and don't open up very well. So if an infant was born premature, they may have respiratory problems through their whole life. If that's something that's the case, they, or at least generally their parents, know it. So be aware that they may tell you, my child has whatever, lung disease. You may also have children with heart disease. It's not super common compared to adults. It'll usually be something congenital. They were born with it. Neurological disease. Again, kids can have a lot of things wrong with them just like adults can. Children with a chronic disease or altered function from birth. So if a child has autism or Downs or a lot of different options, just like any adult patient, there's slightly different challenges in terms of treating somebody who's not your typical basic level patient. Tracheostomy tubes, do you know what those are? Like the hole in the trachea to help them breathe, and so there's a tube in there and that's what they breathe out of. For whatever reason, they can't breathe properly. Maybe, anything from an obstruction in the upper airway to other problems. So with these tubes, you may see obstruction in the tube itself. There may be bleeding around the tube. These are not things that stay in for super long periods of time, generally speaking, unless the person has had some massive upper respiratory issue, somebody who's got a lot of gum cancer or something, or larynx cancer. They may have a tracheostomy tube they use all the time. Otherwise, this is, more of a temporary type thing. But these are some complications you could see from those. Yeah, that's what they look like. The tube in the neck of the kid. Some kids have home artificial ventilators. If one of these is malfunctioning, there's not really anything you can do. You don't know how to properly work one, so don't try to go in and troubleshoot it. You would just treat the patient as best you could. Give them oxygen. You may have to ventilate through BVM or something and just transport them. If you've got a kid that has a central IV, again, potentially obstruction, potentially other things could be going wrong with it. It's not something you can deal with. You just deal with any life-threatening conditions that you could find and treat and transport them. Gastrostomy tubes, y'all know what those are? Those are the openings into the side that aid with digestion. Usually it's a tube going into the stomach that actually gives them nutrients that way. So for patients who have gastrostomy tubes, like they may be more of a permanent implant due to other complications or other pre-existing conditions, you pretty much still treat them like you would any other patient. You have to worry about their airway, oxygen, things like that. Be especially alert for altered mental status, and also be aware that a patient with a gastrostomy tube may be more prone to gastrointestinal issues. So you want to transport them in a way that they're not likely to, say, throw up, for example. So sitting or on their right side versus a way that is, their stomach being over here on their left side. You don't want to be sitting, transporting them on their left side in a way that's going to put a lot of pressure on their stomach. Okay, a patient who has a shunt, which is meant to keep a blood vessel open. Again, open airway, ventilate them if necessary, transport them. It's kind of the same for all these patients. There's not really anything you can do for these special considerations. Just be aware that you may see them, and you have to treat the patient like as much as they need, but they may need more, more rapid or more vital care because of these extra issues they've got going on. Okay, hopefully not too much longer. So dealing with pediatric patients as an EMT. We've talked a lot about what you can do for the patient. We need to talk briefly about what effect dealing with pediatric patients has on EMTs. Pediatric calls are usually the most stressful ones that you'll deal with because, for one thing, nobody likes seeing a child in pain or hurting or sick. For another, you guaranteed have more than just the child to deal with. You absolutely have family, parents at the very minimum, if not even more than that, and the family is usually not going to be calm about this. No one really likes to see a kid hurt, so everyone's going to be a little bit more frantic and more stressed out than they would be during an average emergency. Not so much an issue with you guys because y'all don't have kids, but if you do have children or know children really well, like brother, sister, or something like that, that you have a very strong bond with, it may also affect you because not only is it hard to see kids in pain, but you may associate them with the kids that you feel very strongly for, and make it that much more difficult for you to kind of mentally move past whatever situation has happened. Some EMTs are anxious about dealing with kids if they don't feel like they have much experience with them or much know-how. So again, that adds to the stress. And obviously it's most stressful when the child is very sick, injured, abused children who actually die as a result of whatever has gone wrong with them. All of those situations are very stressful. So in terms of dealing with stress, if you feel like you're not super confident in terms of how to deal with pediatric patients, you can just learn basically and practice how to communicate with them and treat them in a way that relieves stress for you if you feel like you know what you're doing. You know this, we've talked about it, but basically what you have to do for pediatric patients is pretty much what you would do for adult patients, except remembering that your patients don't actually understand anything. So same basic kinds of care, just scaling it down, using slightly different equipment or slightly different words to explain whatever it is that you're doing. Okay, and that was the end. So does anyone have any questions about pediatric patients, pediatric situations, anything that you specifically care about that we didn't talk about a ton, anything at all?